No, no, I had that same feeling yesterday. I was like, oh, okay.
Alright.
Good morning.
School is easier than working.
That is true.
I hate it.
Alright. I'm gonna move stuff. And while I go switch out my notebooks, if y'all want to QR polls everywhere, you can. Oh, I'll go grab them. Yeah, sorry. I think I'm right down the other ones. To join what?
To join the like.
Yeah, yeah, yeah. I will pull this up bigger here. And minimize this. Yep, yep. You can either go to poll Ev or you can text it. And I will I'll leave this up till everybody's here and then I'll show the picture again. Yeah, that's a lot better because the instructions are at the top and the projector cuts off. So this is helpful. Oh, it's 10. There we go. Just a sec. I got some buzzes earlier. I'm going to make sure I didn't. Wow. Okay. Glad that I didn't panic for that. Here are the series of texts I just got from my daughter's school. The power is currently out at the building. If you need to contact the school, please email us. Their phone must be run by power. Then, about 20 minutes later, due to the extended power outage, we'll be closing for the rest of the day. Please come pick up your children. And then 4 minutes after that, power was just restored to the building. The school day will continue as normal. This is the joy, absolute joy of parenting. It's never boring, that's for sure. Alrighty, so everybody go ahead. I think I might do more of the warm activities using Poll Everywhere from now on because it's kind of a fun interactive tool. And if y'all are tired, you don't have to talk out loud, but everyone can participate. So here are the two ways to join. So you can either go to pollev.com and you enter my name, Taryn Myers 601. And then, or you can join by text. You can text Taryn Myers 601 to 37607. And then in a minute, I will show you our. And it's awesome, but just a little clunky sometimes. So let me put it back here. So it's going to make a word cloud as you all respond here, which I love. Nothing scientific about a word cloud, they just look really nice. And as more people come in, it is going to change the word cloud. I'll give it another minute or two here. And those of you who are on Zoom, you can also join. All righty. And it might change as I start to talk about it. Okay, so walkings, people are saying walking. Brain, you listen to brain. Love it. Give us a little more functionability here. Colorful, definitely. This is one of the 3 colored Rorschach blots. People are saying buffalo or hyena. I'm guessing for these things. Uterus, yes. One thing I forgot to mention on Monday is that the Rorschach blots are very purposefully made to suggest sexual organs. So this one's not quite as pronounced, so you certainly see a uterus maybe here, or a couple places. But there are some where like it would be like this, but there would be a phallus sticking up from the top. And that's on purpose. They're gonna see if people will get that. A lot of people are seeing brain. I think that's a little bit of a bias from psych majors, right? People who take a lot of psych classes. But yeah, resembling something. People have opinions about things. People are saying helmets, humans, river. Yeah, maybe because of the color spring. Nice. Outfit. Time bank 2. People are saying 2. Yeah, because it's reflective. So you might see 2 of something. Butterflies. Yeah, butterflies I would say are like one of the most common things people say about just about every Rorschach blot because of its symmetry. So again, kind of a fun little warm-up activity today. Gives you an idea that you can have lots of different answers to the Rorschach, and there's no right or wrong one, which can kind of drive people who are perfectionists crazy. Because they'll kind of look at you like, did I say it right? And you're like, there's no right, right? So let me go ahead and get the captions on. For whatever reason, they didn't work during my last class, but looks like it is going to work here. Okay, that's good. All right, so that was the Rorschach, one of many projectives. And so next, we're going to talk about the TAT, thematic apperception test. And so the TAT is these type of images. So there are 30 black and white cards which show ambiguous situations, and participants are asked to make up a story about what's going on in the picture. So who they identify with, the emotions that they talk about, and the themes that they bring up over and over are all used in interpretation. The really interesting thing to me about the TAT is that, like, there's I think it's like 30 cards, and you don't have to give all of them. You can just like choose whichever ones you want. People kind of choose their own favorite sets. It's sort of a weird way to think about testing when a lot of the other testing we do is very regimented, right? Anyone feeling brave enough to say what might be going on in, let's say, the picture of the woman with the cat? And again, I never give the TAT, so I'm not actually analyzing your responses. Yeah, Michaela. Yeah, maybe he's really sick and dying, and she's sad that he's sick or dying. What else could be going on? I can tell you some common ones people have told me in the past. Some people will say she cheated on him. Other people will say she just found out he cheated on her, right? I think a lot of that probably has to do with personal experience, no judgment, right? But yeah, the dying one is really common. Things are like she has to leave for some reason, the Romeo and Juliet situation. And each of those things would kind of give you, as the examiner, a little piece of information, and then you'd look for themes that come up over and over. So like if they're talking about death and dying every time, you're gonna wanna ask like, hey, did anyone just pass away recently? And if not, you wanna really probe for suicidality, right? If they're talking about being cheated on a lot, probably wanna follow up on that, right? Things along those lines. The simplest projective test, and the one that I gave most frequently, is sentence completion. So we had in grad school, we had to give, I forget how many, maybe 5, maybe 10 comprehensive evaluations during our time that we were seeing clients. And so for a comprehensive evaluation, we had to do, I think, an intelligence test, a personality inventory, which we'll talk about in a few minutes. The interview we always did with everybody anyway. And then some sort of projective as well. And so I, like most of my colleagues, would choose this one because it's self-report. People fill it out pretty quickly. And then you're able to go from there pretty rapidly. And so you just say like, I wish, and the person makes a sentence with that. I wish that I didn't have to be here today. I wish that, you know, I was a millionaire. And then again, because it's a projective and it's based on Freud's theories, you've got stems like my mother, right? And you see what comes from that. And again, you're going to look for patterns, things like that. Some of these do have sort of more standardized scoring, but some of them are more lax. I remember one in particular, and again, this is going to show assessor bias, but I was assessing someone that a friend of mine in the clinic was seeing for therapy. This woman had gone through electroshock therapy which is something we still do, although we do it much more controlled way. And a rare side effect that happens is that some people will experience memory loss. And this woman was worried about that. And actually, she did experience some memory loss. I discovered through that. But I decided to give her this. And what kept coming up over and over were thoughts about food and food being like evil or bad. And again, my eating disorder background kind of brought those to attention for me. But I told Wendy, my friend, I said, hey, this might be something you want to bring up with her. And it turned out, yeah, she was like eating to cope and then feeling guilty about it. And so it was something they kind of brought into their discussion about her depression and her symptoms of it. So some cool stuff from there. All right, next we're going to talk about the ones that I gave most often in a clinical setting, and those are the personality inventories. These are usually giant, 300 plus questions. And they're designed to measure broad personality characteristics. They focus on behaviors, beliefs, feelings, and they're usually based on self-reported responses. So you're giving the person this and they're sitting down and taking it. I want to say like the SAT, but sort of like they're just sitting doing it. And it's important to note that only standardized psychological personality tests should be used in clinical practice as much as questionnaires like these BuzzFeed quizzes might be kind of fun. I don't know if you guys can read it, but it says, what is your favorite color? Do you choose red? And it says, you are red. Red is the color of anything red. Red is a 3-letter word. And then it says, it's sad how some internet quizzes just don't even try anymore. But yeah, when I was in grad school, there was a website called tickle.com where people would take these type of BuzzFeed quizzes. And for a while they were on Facebook, which was interesting. My favorite Facebook quiz I ever took was, are you a hamster? But it was spelled wrong. I was not a hamster, shocking. So these are fun. These are things you can do just to sort of like, kill time. Maybe you find out a little bit about yourself, but they shouldn't be used in a clinical setting, right? So the first one I'm going to talk about is the one I am most trained in. We gave one of these to every single person who walked through the doors of our training clinic, and that is the Minnesota Multiphasic Personality Inventory, or MMPI. So the MMPI consists the original, well, this is the 2, I think, that I have this data for, 567 self-statements. And an individual responds to each by saying, it's true as it applies to me, it's false as it applies to me, or they can technically leave it blank, and that's scored as a cannot say, which just means, I don't know. The reason that they still include like cannot say is that when this first started, the way they have people respond is they give them the items on like index cards and they sort them into piles. Yes, this is true of me. False, no, this isn't true of me, or I cannot say. Some examples of items on the MMPI are, I would rather win than lose in a game. I am never happier than when alone. My hardest battles are with myself. There are different types of scales. So the clinical scales assess symptoms of disorders like depression, or personality traits like introversion. Side note here, I just have this on the bottom that I say scores of 65 and above are interpreted. This depends on the interpretive method you use. This is better for later versions of the MMPI, but for the original MMPI and the MMPI-2, which was the revision, there was no standardized scoring that came in the manual. And so you had various well-accomplished personality psychologists who developed their own scoring methods. I was trained in the Graham method because I was trained by Jack Graham. But the green method, you interpret scores of 70 or above. So if you look through stuff, you might see 70, you might see 65. Validity scales are really important. These assess essentially how much you're paying attention to and being truthful on the test as you take it. So it can assess things like, did you just go through and answer all true, right? Did you go through and kind of randomly respond? Draw some pictures with the bubbles, right? Some more sample items here. I'm sure I get a raw deal from life. Evil spirits possess me at times. No one knows it, but I have tried to kill myself. Obviously, that's one that you want to pay attention to as a clinician, right? Most people make friends because friends are likely useful to them. That goes on antisocial personality, as you can imagine. All right, so this is an idea of how you get the scores back as a clinician. So you have them fill out, and actually now you can do it online too. But traditionally, you have them fill it out, they get a booklet, and then they get a Scantron sheet. And then you run the Scantron sheet through a processor, and the computer program gives you the scores. And then you get a lot of really interesting, good information about the person. So the validity scores here, all low enough, but this says this person answered truthfully. This person is actually engaging with the test in an accurate way. And then the clinical scales here tell you different things about the person. So here they are high on physical complaints. Typically, this is either someone who has actually a lot of health problems, or if they don't have a lot of physical health problems, they externalize their stress. So their stress comes out in headaches, aches, pains, gastrointestinal issues, things along those lines. The highest score is depression here. So this is someone who is definitely depressed. We see a little bit of elevation on scale 7 here, which is, these have old-fashioned names, and it is psychesthesia, which just means anxiety, fancy word for anxiety. They're also a little high on scale 8, which is traditionally referred to as the schizophrenia scale. This does not mean this person actually has schizophrenia. What usually happens when we see this high with other scales is that this person is experiencing confusion or is so overwhelmed they have trouble concentrating, which is a symptom of depression. This person also scored high on the measure of introversion, social introversion. So we know this person is also not necessarily going to be the life of the party, which is fine. So the MMPI was developed using a method called empirical keying. And so this is a very non-intuitive way to create something, but the idea is to try to remove as much bias as possible from the wording of the items themselves. So the first thing you do in empirical keying is you're going to gather lots of items. And so maybe you write some, maybe you find items. Items could be questions or statements. Maybe you find them on other existing inventories. Ironically, when people do empirical keying now, they get a lot of the questions from the MMPI. So it's sort of become empirical keying section. Then you administer the items. So you're going to give them to lots of people. And in the case of empirical keying, what you want to do is give them to people who are already divided into groups. So when they initially developed the first version of the MMPI, what they did is gave them to people who were inpatient hospitalized for disorders who were diagnosed with that disorder, and then a group of controls. So, for example, if we want to see what items should be on a scale of depression, we're going to give all these items to the people diagnosed with depression and a control group. And then you're going to compare their answers. Between the groups. So the items that the people who are depressed always said yes to, but the people who were not depressed didn't say yes to, ended up on the depression scale. And then you're gonna do, oh, just quick note with this. The test makers, because this is how they're doing it, right? They actually don't care what the content of the items are. They don't care what they say. And one of the original creators of the MMPI used to brag that he had never read all the items. Interesting brag, right? But, you know, for example, for a long time, the first item on the MMPI was, I like reading mechanics magazines. Again, random, right? Then after you do this, you're gonna do what's called cross-validation. And what this means is you're gonna give it to a different group of people and try to see if you can predict who is actually diagnosed with depression. If it succeeds, that is, if you can actually differentiate between the people who are diagnosed and the people who are not, then that is ready for use. If it's not, if we're seeing a lot of overlap, then we need to re-key it. We need to redo it, re-hone it, repeat it. There were a lot of problems with the development of the original MMPI, and in particular with the sample used. So I mentioned that the control group was supposed to be non-pathological, no diagnosis, right? Well, what they use as their control group were the family and friends of the patients in the hospital. We're visiting them in the hospital. What could be a potential problem there? Why might that not be a nice, clean control group? No, really. Exactly, genetics, right? But, you know, we know that depression, and in fact, we've known since like ancient times that depression tends to run in families, right? So there's a genetic component. And also, just that environmental factors also come into play that can make people and families all happy. Right? So like if your whole family is dealing with a loss, right? Then you might all have symptoms. Yeah, so it wasn't as clean as they hoped. Another problem is that this was the 1930s, 1940s, and all the sample was from Minnesota. What could be the problem there? Seasonal depression definitely could be a part of it. Sure. Yeah. Yeah, they're all from one place, and in particular, what do you think, like, people from the upper Midwest in the 1930s were probably like? They're super white, right? They're super white, they were mostly farmers, and so, like, it just wasn't representative of the US as a whole, much less the world as a whole, right? So there's a geographical and an ethnic bias, and obviously that causes problems. So some revisions, and I realize I need to put the 3 on here, so that's on me for not updating. But in 1989, they published the MMPI-2. It has a much better sample. It has new norm. It had new norms. The new norms were the primary goal of the revision. They actually called it the MMPI Restandardization Project. So they purposely got people who were representative of the US population as a whole. They also introduced some new items that measured some things the original MMPI didn't get at. And then they also had to remove some items that used outdated language or were just illegal to ask. The MMPI is sometimes used as part of workplace screening, particularly for folks like police officers, firefighters. And so you can't ask illegal items, you know, in questions like that. So when I was in grad school, 2008, the MMPI-2 RF came out. The very cool thing about being in grad school when this happened and being at Kent State, where I got my degree in particular, was Yossi Ben Porath, who was one of our assessment professors, was actually the co-author, and I think he's the first author on the revision. And so he gave us a workshop on it. We were, I think, like the first group to get a workshop, which was really cool. He probably piloted his presentation on us. So this is built off the creations of what they called the restructured clinical scales. And so what Yossi and his research group did is they started looking at the fact that, you know, if I go back a couple slides, or just one slide to this, we typically see people with elevations on multiple scales. And particularly like the depression, the anxiety, these sort of physical complaints. And so Yossi actually went in and used a method called factor analysis that we'll talk about in a couple minutes and sort of reanalyze these items. And what he found is that there were a core group of items in the original clinical scales that were essentially the same items that ended up on multiple scales. And these were items that measured what they ended up terming demoralization. Because when you are psychologically not well, you just kind of feel like crud about it, right? You feel kind of down, you feel kind of demoralized. So they pulled those items out and made it its own scale. They call it the RC demoralization subscale. And then that leaves you with much cleaner scales that measure the other clinical things. And it's really sort of interesting how some of them played out. So like the one that we used to call depression, now is really more indicative of what they call low positive emotionality. That means you're just like less likely to be happy. And that's a big indicator of depression. It's also shorter, and the MMPI-3 is really similar to the RF. So the RF was 338 items, and they made sure there were no overlapping items at each level of interpretation. And they used the factor analysis, which I mentioned. So they did do extensive research on it, but they did not re-empirically key. They did not go through this process again. So these are Jack and Yossi. These are my assessment peeps. They are the reason that Kent State is consistently rated in the top 3 in the country for assessment training and research. Maybe not surprisingly, the University of Minnesota is still up there, you know, because like they came up with the MMPI. But Yossi really is one of the driving forces behind these modern revisions of the MMPI, which is really cool. So when I did a training on the MMPI-3, it was a webinar, and I got to essentially take class with Yossi again, which was really cool. And as I mentioned, this is Jack's book that we use to interpret the 2. The 2 RF and the 3, the user manual comes with an interpretation guide. So you no longer have to like figure out which method you're gonna follow. All right, the PAI, this is the Personality Assessment Inventory. This is also short, 344 items. A little different than the MMPI because instead of just true or false, you have more of a Likert scale. So you can say it's false, slightly true of me, mainly true of me, or very true of me. The PAI, interestingly, is what is used extensively at the VA. So when I was at the VA, I learned how to give and interpret the PAI. It's actually built into their software and it integrates right into their digital record system, which is really nice. So it also has validity scales and clinical scales. It has treatment consideration scales, which the 2 RF and the 3 have of the MMPI. And then there are interpersonal scales about sort of how you interact with other folks. It was developed using what's called the rational method. And the rational method is where you just take items that seem to measure what you want to measure, and those are what become your items. So it's face validity, essentially. So you come up with the items directly, obviously, and rationally. It was described by the test creators as being developed conceptually. And what they had was clinical judges, so experts in each subfield, so like people who study depression or treat people with depression. They showed them the items and the judges rated how much they said, yeah, this is actually measuring depression, for example. Some sample items from the PAI. People are afraid of my temper. People once close to me have let me down. I can talk my way out of just about anything. This is what a PAI output looks like. I really liked this about the PAI. So with the MMPI, it's just sort of like standardized norms that it's compared against. And there are other things you can kind of look up for specific samples. The PAI, you get to choose who you're comparing against. So they have norms for people who are in outpatient therapy, people who are in inpatient therapy, things along those lines. And then those are displayed in what they call the skyline, this blue line system at the top. And then you compare your person's scores, the black line, to the skyline, as well as sort of the reference point. And here you can see this person scored normally on everything, nothing popped up. Alrighty, so then we have the 16 PF. This is an older personality test or inventory. This was derived by Cattell. We're going to talk about Cattell a lot through this class. It'll come up in a couple different chapters, but particularly trait theory. So he derived the 16 PF based on words and statements describing personality. It's 185 items. It has 16, hence 16 PF, primary personality scales. So 16 personality factors, personality scales. And then there are 5 global personality scales. Example item from this inventory: when I find myself in a boring situation, I usually tune out and daydream about other things. And so they used factor analysis to derive the 16 PF. And factor analysis is a statistical method for finding order amongst chaos. So basically, statistically, you get people to fill it out, and then you can tell a computer program, this is what I want to do. And it groups things based on what the math says. The math says these items all relate to each other. And so it finds groups of things, like groups of questions or items that are alike statistically. So you could administer it to a large number of participants and then see what items hang together statistically. That's factor analysis lingo. Do they hang together? This is a really crummy resolution picture of a 16 PF scale. Because it's older, it's not used as much, so it's hard to find examples online. What I really like about the 16 PF that's more clear than any of the other inventories is that everything is double-sided. It's not just like kind pathology, it's looking at both sides of everything issue. So like this bottom one is relaxed versus tense, right? And so you're going to be able to see where they fall on that range. And it also does it in percentile rank rather than standard scores, which is what the MMPI and the PAI use and are a little harder to interpret without additional trading. All right, going to talk about some other types of tests, in particular self-report inventories. These are the most commonly used in research. They're questionnaires completed by an individual, often much shorter than something like the MMPI. They might only be 20 items. Long ones that I've seen are only 60 items. Some are only like 5 items. And they focus on one specific area of functioning or personality. So they might focus on affective issues, mood, depression. They might focus on behaviors like social skills. They might focus on cognitive issues like your thoughts and assumptions. And with self-report inventories, you're given a questionnaire. Again, nowadays a lot of times they'll be online and you complete them that way. Traditionally, they've been pencil and paper. And you're gonna just answer which one best fits for you. This is a few items from the Beck Depression Inventory, and it gives you an indication of some of these that might be used. So what I really like about the Beck Depression Inventory is that it doesn't only use the like traditional symptoms of depression to get suicidal ideas or a symptom of depression, something that we need to test. I don't have any thoughts of killing myself, all the way to having to kill myself 500 chance. All right. This is the first one you look at when a client hands you back at the back depression. But they also get into more specifics, like how is your depression getting in the way at work, right? I can work about as well as before, all the way to I can't get any work done at all, right? This is really important about a person's quality of life, right? And their ability to do what they want to do. And then loss of libido. Again, something people don't often think about, something that people are hesitant to ask about, but important for a lot of people, right? It can really affect the quality of your relationships for a lot of folks. So I've noticed no recent change in my interest in sex, all the way to I have lost interest in sex completely. The cool thing about things like the Beck Depression Inventory, I think it's 21 items. And so people can fill it out really quickly, 5 minutes or less. And so you often, when you're doing therapy with someone, for example, and they're seeing you for depression, you might have them fill this out every week to see how they're doing. And so it lets you track how they're doing over time. Really nice. All right, well, we also have some modern things that we can bring in now. So I'm going to talk about neurological and neuropsychological tests for a few minutes. These are less about personality, although certainly we're using some neurological things to try to figure that out, but more things that would be incorporated into larger scale assessments. So neurological tests are going to measure brain structure and activity directly. So the simplest version here is the electroencephalogram or EEG. This little kiddo in the corner is wearing a version of that. Sometimes they actually have different electrodes they stick directly to you. And it basically just looks at your brainwave pattern. So these are really commonly used for folks who have epilepsy to look at their seizures. These are used during sleep studies for people that have sleep apnea, sleep terrors, things like that. It can also, again, just sort of get a good baseline. So this is pretty non-invasive, but it's not really going to tell you much about brain structure, just brain function, right? So if you want to get into brain structure, then you're going to look into neuroimaging, and that involves taking pictures of the brain. And it can be still, like an X-ray, or more often now, particularly if we're looking at it in sort of the context of personality research or assessment, we can do it more like a video while a person performs a task. So the CT or the CAT scan stands for computerized axial tomography. Y'all never have to write that out for me. CT or CAT is fine. And it uses X-rays of the brain structure taken at different angles. So this shows you an example of what the CT looks like. And then this shows you what the output looks like. So you can see a bunch of series of kind of like slices through the brain with X-rays. On any of these scans, anything that's like really bright colored or really dark colored is usually problematic. So these right here are called the vesicles. That's normal. Everybody has those. This is not. So this is most likely a bleed into the brain. So that's blood that's sitting on the brain that shouldn't be. These types of imaging tests are usually given by an imaging technician, so like an X-ray technician, and then interpreted by some sort of medical doctor. There we go. Here's the words I was looking for. So a neurologist or something along those lines. Even though if anyone's ever had this type of imaging, you know the techs know. Like I remember one time they were trying to figure out, I was having some gastrointestinal issues. And they thought I might have gallstones. And the tech was training someone else and she was like, here's where the stones would be if there were any. And then afterwards she was like, so I can't tell you the results. I was like, sure, right? Anyway, all right, the MRI stands for magnetic resonance imaging, and it uses the magnetic properties of certain atoms in the brain to create very detailed pictures of the brain. Here again, anything that's sort of standing out like that, that's a massive tumor in this case, right? That's what's problematic. These are higher resolution, but they can't be the first line of defense if someone's like brought into the ER unconscious, because it's a giant magnet. So if someone's brought in unconscious, you don't have a medical history, no one came in with them. You can't do this because if they have metal anywhere in their body, it's not gonna like tear it out, but it's gonna move it around. So if any of you have like screws in your knees or your ankles, people with pacemakers, right? You don't want to be moving those around in the soft tissue, right? So if someone can give you their medical background, no problem. But otherwise, we usually default to a CT until that person can be awake. The MRI actually won, or the people who created the MRI won the Nobel Prize for Medicine in 2003. The PET scan stands for positron emission tomography, or PET. This is a computerized motion picture of chemical activity throughout the brain. Oh, so that's one thing I didn't mention about the MRI. You can do what's called an fMRI, functional MRI. And that's where you would have someone do a task and see which parts of their brain are lining up while they're doing it. And so it's more structural. The PET scan, you're looking at chemical activity. So it's more of an indirect way to look at brain functioning. It also uses antimatter and how it reads. So it's something very sci-fi, but it's real. It's very cool. And so this picture actually shows a normal brain and then someone who is using cocaine. So one of the things we talk about with drug users is that it takes more to stimulate their brain, more to get them excited, more drug, more exciting behaviors, things along those lines. And so this really dates me. This was an ad in the 90s, but this is your brain on drugs. Any questions? Okay, I got one chuckle. All right, woo! The joke was becoming less and less relevant. All right, neuropsychological tests are things that psychologists would give. And for these, we're looking at damage to the brain's abilities. So things like our cognitive abilities, our perceptual abilities, our motor abilities. And so you could have a brain scan, right? And it could say there's a tumor here, or you had a stroke on the side of your brain. That doesn't tell us how that's going to affect your life until we go in and do something like a neuropsychological battery. Okay, that tells us. And so sometimes we'd be doing this as part of a personality assessment, just to kind of like rule out that the personality change isn't due to a change in some sort of like actual function, right? So we know, for example, Phineas Gage, I talked about him with my intro class the other day, right? The guy who had the railroad wire shoot through his head. Most of what was damaged for him was the prefrontal cortex, and his whole personality changed, right? So we know that this can affect it. So we might look at something like intelligence tests, which have different measures on them that tell us about verbal versus nonverbal ability, processing speed, attention, things along those lines. These are very carefully standardized, as I mentioned at the beginning of the lecture. The instructions are so detailed and tell you exactly what to do at each step. Perceptual. So one of these is the brief visual memory test, which you can see in the small picture there. So this is something that you have people just copy these small diagrams and see if they're having any sort of like problem seeing the whole image, copying it, things along those lines. There's also a not surprisingly with its name, a memory component where you ask them to remember and redraw them later. You can also look at things like motor skills. The groove pegboard, the pegs are in like a very specific shape, so each can only go into the hole one way. And you're only allowed to use one hand at a time. So if you do your dominant hand and then your non-dominant hand. And as someone who's very functional, you can't do it very quickly. So someone who had damage in a part of the brain, like the motor cortex, right? This can really tell you what's going on for them. Another thing that we might do is clinical observation. This is a way to more directly examine behavior in particular. So naturalistic observation would be observing the clients in their everyday environment. So probably the most common is when a school psychologist or other mental health professional would come like sit in the back of a classroom and observe the kiddos while they were participating in class. Analog observation is when you do it in an artificial setting. So this is an example, this picture of analog observation. You've got the kid in like a laboratory setting. They kind of know someone's watching them, right? And can be done through this type of one-way mirror, which we do actually have one of these over in the social science lab. We have an interview and observation room. And then self-monitoring is a really common way, particularly once a client is in therapy, to get information about how things are going in their environment. So they might do some sort of diary of their behaviors for that week, what their thoughts were for that week, when and what they were eating, things along those lines. And these used to be mostly on paper, and more they're being done through apps. So now that you all know about clinical assessment, as I mentioned previously, there are some important major differences between clinical assessments and those assessments in the popular media that we run into every day. So I have a couple, here we go. So I have the definitions here. So psychological assessment is well-validated, good reliability, all those psychometrics, and it's based in research and or theory. And popular is usually not any of these things. It's like some intern sat and thought up some fun questions, right? So gonna ask you all, and some of these will be more obvious than others, if you think this is from a psychological or a popular assessment. So what do you think? Would this be something that a clinician would give you or something you'd run across in a more popular setting? All right, we'll do hands. Who thinks this would be clinical? Who thinks this would be popular? Yeah, I think this was from like 17 magazine or something like that, all right? I feel that I get a raw deal from life. Who thinks this would be psychological? All right. Few people. Who thinks that this would be from a popular one? Okay, so yeah, this is from the MMPI. I think the second one is pretty obvious. Also dated. Check your G-Shock. I don't even remember what that is. Okay. How many days per week on average over the last 6 months have you eaten an unusually large amount of food and experienced a loss of control? Who thinks that's psychological? Yeah, I got some hands. Yep. This is from the EDDS, the Eating Disorder Diagnostic Scale. I just showed you this one, so you know it's from the Beck Depression Inventory, right? How about who was Martin Luther King Jr.? Who thinks that's psychological? Right? Who thinks it's popular? Could be on a popular test, but this is actually a question on the Wechsler Adult Intelligence Scale in a section called Information, where it asks you about like factoids. All right, how about which number should come next? 144, 121, 100, 81, 64. Would you say this is psychological? Okay, got a couple, or popular? Couple there too. Yeah, so this is actually, and I don't know if this is still a thing, but when I was in college in particular, it was like really popular to have like your pop-up ads, I got those fun the way of whatever, or your like sidebar ads be like, take our intelligence test. And this was from one of those like fake intelligence tests. Alrighty, So there are no readings to prep for Friday. It's an activity day. I'm gonna bring in assessment stuff to show y'all, and then you'll get the chance to actually fill out and score some assessment stuff for yourself as well.
You too.